Okay, back again. I realize that I'm the last person standing between you and your dinner, so I promise I'm going to finish in 15 minutes, or maybe even less. So really going to just whiz through some of the data for advanced lung cancer, aka stage 4 lung cancer. Same disclosures as the last talk. And I've already mentioned this, that the reason why our current patients do better than patients 20 years ago is because we've got better understanding of what the cancer is. So, for example, back in 1987, only KRAS mutation was known, and then 2004, EGFR mutation came, and 2009, there are more, and now today there are sort of less than 20% of lung cancers that there isn't a known mutation, and more than 80% patients has some sort of mutations, whether actionable or not. So it's just the better understanding over the period of time that has changed how lung cancers are managed. And again, you've seen this slide earlier today. The more the targetable mutations, there are more drugs to it. So you've got a target, you develop a drug, you test it, it works, and you move on, and so on and so forth. So it's same old story. So there's nothing new there. First-line treatment option for metastatic non-small cell lung cancer, as long as there are no driver mutations, you are actually spoiled for choices, because we've got data with pembrolizumab, you've got data for atezolizumab, you've got data for nivolumab, plus or minus EP, with or without chemotherapy. So you've got your Keynote 189, Keynote 407, Keynote 40042, Checkmate 9LA, and so on and so forth. So you've got a lot of options. So the trouble is to decide how do you treat the patient, because you've got 3 or 4 very viable options in front of you. So if you've got a patient coming in through the door tomorrow, and you know that there are wild type, meaning that there are no driver mutations, PD-L1, let's say it's 60%. So whether do I give the patient just single agent immunotherapy, whether I add chemotherapy to the immunotherapy, whether I do a Checkmate 9LA type protocol where you give 2 cycles of chemotherapy rather than 4 cycles with immunotherapy, or whether you do doublet immunotherapy with EP and Nivo like you treat melanoma. So there are a lot of different options. And you'll see that even if you've got the same patient or the same disease in 2 different patients, and you give them the exact same drug or the exact same protocol, they will behave differently. The toxicities will be different, the outcome will be different, the clinical sort of response will be different, which tells you that yes, you can choose from different regimens, but there are more about the cancer and more about the patient rather than just the disease and the drug. And that's why you've got these sort of guidelines where it says that if it's more than 50% PD-L1, you do immunotherapy. If it's 1 to 49%, you do chemotherapy, immunotherapy. It's less than 1%, you do chemo plus immunotherapy. So these are all guidelines. There is a difference between a guideline and a protocol. A guideline tells you what you can do, a protocol tells you what you are supposed to do. And that's where all these sort of nuances of discussion comes in. And this is a really nice meta-analysis which shows that even if your PD-L1 is more than 50%, then if you look at a single trial, it tells you that single agent immunotherapy should be enough, and you should not need to use chemotherapy. However, if you look through the meta-analysis, even with a high PD-L1 of more than 50%, chemo plus immunotherapy does better than immunotherapy alone. And the reason why that happens is because there are multiple patient factors and multiple tumor factors that comes into play. The performance status, whether or not there is liver mets, whether or not there are CNS mets. And PD-L1 is not dichotomous, which means that PD-L1 of 51%, a patient with a PD-L1 of 51% is not going to behave the same as a patient with PD-L1 of 70%. So this big subgroup or this big group of PD-L1 more than 50%, meaning 50 to 100%, a 50% PD-L1 patient doesn't behave the same way as PD-L1 80%, and a PD-L1 90% patient behaves very differently. So it's not a dichotomous relationship. And the other reason why immunotherapy, the same immunotherapy with the same high PD-L1 doesn't work the same way in 2 different patients is because of what actually happens inside the tumor. So there is this concept of the tumors being inflamed or the tumors being cold, and which means that an inflamed tumor which has very high TILs will respond better with immunotherapy, whereas a tumor that is not inflamed will not actually respond to immunotherapy. And that's why things like prostate cancer doesn't respond to immunotherapy, because most of these tumors are not inflamed, whereas melanomas and lung cancers are, by definition, mostly inflamed tumors, and therefore they will respond better to immunotherapy. And this is quite a nice data from the Empower Lung 1 trial, looking at cemiplimab, first-line cemiplimab in stage 4 lung cancer, metastatic lung cancer. And it just shows you that a PD-L1 of 50 to 60%, and then a PD-L1 of 60 to 90%, and a PD-L1 higher than 90%, they all behave differently. And the median overall survival is actually double if you compare 50% versus more than 90%. So PD-L1 is not a dichotomous thing, it's a dynamic thing. The other thing to remember is intra-tumor heterogeneity. So you can have metastatic lung cancer with a PD-L1 of 60% in the lung, and that tumor, when it metastasizes to the brain, can have a PD-L1 of 20%. So, and they will behave very differently and they will respond very differently. So it's just to sort of be aware of those limitations. And this is a very interesting one. I'm just going to sort of leave this slide with you to think about it tonight, and I'm sure you'll get excited about this. This is very, very early data, and there is a lot of excitement around this. I received $1.5 million of a research grant only 2 weeks ago to answer this question. So hopefully my team can answer this question in years to come. So the idea is, if you give the first 4 cycles of immunotherapy in the morning, rather than give the first 4 cycles of immunotherapy in the afternoon, it works better. So giving the first 4 cycles of any immunotherapy before 12 o'clock in the afternoon, preferably between 8 o'clock to 11 o'clock in the morning, then it works better than if you give that same drug to the same patient in the afternoon, only in the first 4 cycles. The hypothesis is the circadian rhythm influences the circulating T cell count, and therefore, if you give the immunotherapy in the morning, there is more circulating T cells in the system, and therefore the drug works better. But only in the first 4 cycles, because after you've gone beyond the first 4 cycles, the immunotherapy drug reaches the steady state, because you've gone through 5 half-lives of that particular drug, and therefore after the 4th cycle, 5th, 6th, 7th, doesn't matter whether you give it in the morning or you give it in the afternoon or even at night, it makes no difference. So really exciting data that's coming out, and hopefully more to come, but obviously we haven't got concrete evidence behind this. But if you could try to give your patients immunotherapy in the morning, at least in the first 4 cycles, and maybe it makes a difference. We obviously haven't talked about small cell lung cancer, and I'm not going to talk about small cell lung cancer, but really just to sort of make a point that most of the advances in thoracic oncology in the metastatic setting beyond immunotherapy is basically coming in the form of theranostics and BiTEs, which stands for bispecific T cell engagers, and ADCs, or antibody drug conjugates. And I'm literally going to spend 1 minute each to explain what they are, and you might already know this. Theranostics is you identify a target on the surface of the cancer cell, you develop an antibody that will go and bind against that antigen, and you tag that antibody with a radioisotope, and that's theranostics. So you inject the compound, the antibody goes and binds against the antigen on the cancer cell, and it releases the radioisotope locally to have a local effect on wherever the cancer cells are. This year's ASCO, there was a plenary session on small cell lung cancer where one of the theranostic molecules where the early data was reported. DLL3 was the antibody, and I think they used lutetium as the radioisotope. Really, really exciting data. So that's coming hot and fast. Antibody drug conjugate, it's not a new concept. In the breast cancer world, we've been using TDM1, etc., for a long time. Basically, again, you identify a target on the cancer cell, you develop an antibody, and then you attach a cytotoxic payload, and that's tagged along with the antibody with a cleavable linker. You inject the drug, the antibody goes and binds against the antigen, and then the linker cleaves or breaks apart and releases the cytotoxic payload locally to have a cytotoxic and a bystander effect. Many ADCs are currently in use, and many ADCs are currently being tried in trials, and they're all coming really fast. ADCs, there are several ADCs that are already approved, so HER2, TROP2, CMET, these ADCs or ADCs that uses these molecules as targets are already approved, and then there are others that are also coming. So watch the space. Again, just a list of some of the other ADCs coming through the pipeline, so I'm not going to bore you with that. BiTEs are super exciting because bispecific T-cell engager, basically you've got an antibody that attaches PD-L1, and then you've got an antibody that attaches to CD3. So it's literally physically forcing the cancer cells to come closer to the activated T cells. So it's not leaving the immune response to chance, it's forcing the T cells to come in direct contact with your cancer cells. The problem with BiTEs, well, not a problem, but the main thing is the BiTEs can be so effective that in the old days when we used to teach about small cell lung cancer, we used to talk about tumor lysis syndrome, right? So that's a very common thing. So kind of a similar concept happens with BiTE, that because these drugs are so effective and it induces such a profound immune response that a cytokine storm essentially happens. So cytokine release syndrome, or CRS, is a very significant toxicity of this class of drugs. The risk of a grade 3 CRS with BiTEs are at least 65%, meaning that almost every 2 out of 3 patients will have a CRS, and you can actually kill the patient with CRS. So if we are using BiTEs, we normally admit the patients and do the first 2 cycles as an inpatient to really have close monitoring, but more importantly, if the patient does develop CRS, you need to have access to drugs like tocilizumab and similar classes of drug, because otherwise, yeah, it can be fatal. But that's also quite exciting. You might have heard about the drug called tarlatamab in small cell lung cancer. Really exciting data. It has doubled the overall survival in the second-line setting. It's coming into the first-line setting. High risk, high value drug, meaning that high reward for the patient, but high risk for the oncologist. Similar concept, bispecific antibodies. You've got PD-L1 inhibitor and tagged along with another identifiable molecule, and you make those 2 molecules in a single molecule. So these are the kind of things that are coming through the pipeline. Some of them are already in clinical practice. So I'll just leave it there just so that you know what are the things that are coming through. So I've finished in 15 minutes. Thank you.